Let us continue our discussion of part 2 of third stage of labor and atonic postpartum hemorrhage. So first now we'll understand the management of postpartum hemorrhage. So the first step which you need to do for the management is you need to do the uterine massage and do the non-specific measures, and after that do the specific measures. So this is how you need to manage the patient. So first uterine massage, non-specific measures and specific measures. So what is the second step? In the second step you need to do further management. It depends on type of PPH. So first you need to do uterine massage, next non-specific measure, next specific measure. That is the first step. Second step, further management depend on type. So even after doing this measure still it is bleeding, then you need to do further management. So first we need to see what is non-specific. So the non-specific measures are insert 2 large bore IV cannulas, 2 bore large IV cannulas. Okay, and next is start RL or NS. Do not start dextrose 5%. Actually we should give these solutions only with RL or normal saline, but we should not give with dextrose 5%. That is like oxytocin. For example, take oxytocin, we will mix this oxytocin only normal saline and give it, or with RL, that is our lactose. Otherwise we will not mix this with dextrose 5%. And we need to take some investigations like blood group, RH typing, and we will do CBC, okay, complete blood count, and we will also arrange the blood ready so that when more blood loss we can give with fresh frozen plasma, and also we will catheterize the patient. So this is a non-specific treatment. So first we will insert 2 large IV cannulas. We will mix oxytocin with normal saline, and we will do the blood group, we will do RH typing, we will do CBC, we will arrange the blood and catheterize the patient. Those are non-specific. So this is the first step. After that we will do specific measure. Specific measure is injection Trenexa. Injection Trenexa is recommended by WHO, especially in atonic PPH or in traumatic PPH. Especially in this both PPH we will use this, and we'll start the Trenexa within 3 hours. We'll start this within 3 hours of PPH. Okay, and the dose is 1 gram per 10 milliliter of normal saline and slow intravenous. So doses we will give 1 gram per 10 milliliter of NS. Okay, start Trenexa within 3 hours. So what is the purpose of uterine massage? It helps to contract the uterus, okay, help in diagnosing the cause of PPH, especially in atonic PPH. Uterus will not be palpable per abdomen, and in traumatic PPH uterus will be palpable per abdomen. So let me write it here. Atonic PPH not palpable in abdomen. Coming to traumatic PPH, it is palpable in abdomen and in retained placental tissue. Retained placental tissue, there's intermittent contraction and relaxation of uterus. Okay, so now coming to further management of atonic PPH. In atonic PPH we will give medical management with uterotonic drugs for 30 minutes, And next we will go for mechanical compression. If even mechanical compression fails, we will see the vitals of the patients. Okay, if the vital of the patient is stable, okay, so if the vital is stable, we will do uterine artery embolization via femoral artery, or you can apply compression sutures surgically. So even this fails, then you will go for devascularization surgery. Okay, so devascularization surgery, here you will do bilateral uterine artery ligation. So even if this will fail, again we will check the patient vitals. If it is stable, okay, you will ligate. So this is important. If it is stable, ligate anterior division of internal iliac artery. If the vitals are unstable, then we will do hysterectomy. That too we will do subtotal hysterectomy. So now coming to medical management. So first, you know, the drug is oxytocin. You will give 20 international units, either IV infusion or intramuscular, already discussed in the first video. Okay, what are the important points? Never give oxytocin IV bolus. Never dissolve it in dextrose 5%. The first line drug recommended by WHO to prevent or treat the PPH. If it fails, then go for second line drugs. So the second line drugs will be methylergometrin. Methylergometrin give 0.2 milligrams intramuscularly. Repeat every 20 to 30 minutes. Maximum dose, give 5 doses. Never give it IV as it can cause hypertension. Next, coming to carboprost, dinoprost or hematabate, which is PGF2 alpha. Give 250 micrograms intramuscularly. Repeat every 15 to 19 minutes. Maximum dose is 8 doses. Side effects are diarrhea, contraindicated in asthmatics. So it is the most potent drug to treat PPH. Carboprost or dinoprost, most potent drug to treat PPH. Okay. So next, coming to misoprost. Misoprost 800 micrograms given sublingually, recommended by WHO. Can be given per rectally, causes least side effects but take longer time to act. WHO doesn't recommend to give it per rectally to treat PPH. Dose 800 to 1000 micrograms per rectally. Side effects are fever, shivering, contraindicated in previous C-section patients. Now coming to mechanical compression of uterus. Okay, so here it can be done by SP esophageal catheter, Bakri balloon catheter and condom catheter. So mostly we use Bakri balloon catheter. Actually we fill the bulb with the normal saline, we will inflate it and will press against the open sinus. So the maximum capacity of Bakri balloon catheter is 500 milliliters. Next, coming to compression sutures. So in the compression sutures, the most common suture is B-Lynch suture. Okay, so actually B-Lynch suture is where we will keep the suture throughout the uterus. Okay, and next one is Hyman suture, next one is Gunshela suture and Co-square suture. Next, coming to devascularization surgery, indications is if after mechanical compression patient's vitals are unstable, and if compression sutures fail to control bleeding in a patient whose vitals were stable. The most common artery ligator is uterine artery, that to bilateral ligation. Next, coming to anatomical fact, uterine artery crosses over ureter 2 cm lateral to the internal os. So subtotal hysterectomy is the final one, also known as supracervical hysterectomy. Only uterus is removed, not the cervix. Advantage of quick procedure to perform. Entire cervix and vagina are intact. So important single line is the most common cause of patient going into shock after delivery, PPH. Most common cause for patient immediately going into shock after delivery, uterine inversion due to neurogenic shock. Most common cause for patient going into unexplained shock after delivery, amniotic fluid embolism. Temporary measures recommended by WHO to control bleeding in PPH, external aorta compression, military anti-shock garment or treatment, bimanual compression of uterus, and method not recommended by WHO to control bleeding in PPH is packing of uterus. As per WHO, Uterine massage is no longer a method to prevent PPH, but it is a method to treat PPH. So actually this is a fast, like you can say it's like a podcast because we want to complete this faster.